G'day everyone, this is Health Highlights. My name is Simon Ashley. Health Highlights is a show about health professionals and the people and the stories behind the names that we often hear about but we seldom get to meet. And today it is an absolute privilege to be interviewing one of Newcastle's most renowned orthopaedic surgeons, Dr.Jai Kumar.
Thanks Simon, thanks for having me.
So you may not be aware of this, but we're an ageing population and joint surgery is actually becoming one of the most sought after or used surgeries in all of Australia. 25% of all the operations that happen in the hospital are actually joint surgeries. And it is greatly on the increase. It's about 20% a year joint surgeries are increasing in our communities. So it's going to be great to be able to talk to Jai about what he does and how orthopaedic surgery is changing in the next 5 to 10 years. So Jai, firstly, how is it that you come to get into becoming an orthopaedic surgeon, and particularly your specialty, which is knees and shoulders?
Yeah, so I was born and bred in Newcastle. I was born at the old Newcastle Hospital, and my dad's a GP over in Merriweather, just around the corner from here. And I grew up in a medical family. So Dad's one of those old school GPs that had a doctor's bag, and patients had your home phone number, and they called you at midnight on a Saturday night, and you got out of bed and went and saw them. So I did my ward rounds with Dad and saw patients, had my old Fisher-Price doctor's set. So
wow.
Sort of part of the furniture in the hospital system. And I think when you grow up in that kind of environment, you get a sense of whether it's something you like or not. And the circles we moved in, Dad's friends, colleagues, things like that, I just ended up falling into this role as a doctor. And then I've always loved sport and I was trying to stay fit and healthy. And as a natural consequence of that, I sort of lent into bone and joint surgery, and even more specifically these days into sports surgery and dealing with active individuals.
Fabulous, fabulous. Yeah. So one of the questions we often get is how, as a client, should I prepare for surgery so that we get the best success out of that surgery? So what would your advice be to clients that you see about getting great results in surgery?
Yeah, so it starts from the simple things, which is lifestyle factors. So being aware of your own health, your own medical comorbidities, and trying to live as active and healthy lifestyle as you can. The importance of having a good regular general practitioner who you see regularly, who knows you, is of paramount importance. When you're coming to surgery, your choice of surgeon is important. The reality is that we've all done our training and we're all capable of doing operations. What you're really looking for is a surgeon that you engage with, that you trust. Because at the end of the day, if someone's going to stick a knife into your shoulder or your knee or your hip, you want to be able to trust that person. And I think that's been a huge paradigm shift in the way surgery has gone over the last 20, 30 years. The days of surgeons being someone who sits behind a desk and tell a patient what has to happen have all changed. The internet age has changed and people are aware their expectations are higher. So what I would do is say to a patient, research a surgeon, get feedback from friends or family or colleagues about who's nice, who does a good job, who's going to engage you well and who's going to follow you up appropriately, and make the decision on surgeon after that. Once you're coming to the surgical process, from my particular patient population, I'm very much into the concept of a multidisciplinary approach to total patient care. So I always tell my patients 20% of what you will go through is the surgery, 80% is what you're willing to put in yourself, what your therapist put in, and everything else that happens around it. So a surgeon without a physio is not really a surgeon. A physio without the surgical process is no good. In the operating theatre here, us without our scrub nurses or our scrub scouts are doomed to fail. So for me, such an important part in the lead up to surgery is your pre-rehabilitation and your physical and mental preparation for an operation. So for me, I engage physiotherapists and other allied healthcare professionals well before the operation, so the patient has a great relationship with that therapist, which means when they come back from the operation with their sling on and their saw, they see a familiar face, they know the exercises they're going to do, they know the environment they're in, and it enables that transition from acute post-operative care into the rehab phase.
Fantastic. That's so good, and that's really the way that everything is going, which I think is exactly right. So We love that ATUNE around the multidisciplinary approach. What would you say is your team? So who are the people that are in your multidisciplinary team with you? So you've obviously talked about physios. Who else is part of that team?
GP.
Yep.
Physiotherapist, sports physician, strength and conditioning coach, team coach, team manager, depending on the level of care or level of play. Within the surgical environment, it's a monumental team. In the theatre environment, we have the anaesthetist, the anaesthetic nurse, the scrub nurse, the scrub scout, the operations assistant who basically runs the theatre. We have assistants. I often have an overseas fellow who's someone who's come from overseas to learn how I do particular surgeries. And that entire team is all working together and all knows each other back to front and what each other does. So we're never second guessing each other. So and once you leave the hospital, the beauty of having that multidisciplinary team is everyone's backing each other up. So I often say to my patients, if you scratch your bum the wrong way, your physio will call me to tell me. So do what's expected, otherwise they'll find out about it. And that's the degree of control you want to know that your patient has over their total process. They know they're not going to be that 1 in 1,000 person that slips through the net and gets a suboptimal outcome because the whole team hasn't been watching them the whole route.
So what would you say, that we're talking about outcomes, so what are you seeing is maybe the difference from say what used to be done to now? Are you seeing much better outcomes for clients through surgery?
Yes, and it's not just physical, it's also the emotional and psychological outcomes. So I think that surgery is a scary process for anyone. We're coming into a weird environment with people with blue clothes on, everyone's covering you with betadine or chlorhexidine, cutting you open, doing an operation, you're painful, you're sore. It's not an enjoyable experience. So anything that the surgical team and the rehab team can do to make that process better for the patient is going to improve the outcome for them. So for example, a rotator cuff tear, we can do an operation, send you home in a sling and say, don't talk to a physio for 6 weeks or 12 weeks. Don't do anything because no one knows what I've done in there and hopefully end up with a good outcome. Or you can go, let's engage your physiotherapist, get to know them beforehand. They can focus on making sure your shoulder range of motion is appropriate, you've got best strength you can, you know what the post-operative protocol is, then we have your surgery and send you back to them. As I said, you're going back to an environment where everyone, you know everyone, and it's a familiar place. And there's the broomstick that I use to lift my arm up, or there's the wall that I walk up as part of my rehab protocol. And that, in terms of patient outcomes and the patient experience, is of vital importance. Absolutely. And you get that feedback from patients all the time.
Totally. That's wonderful. So, talking about outcomes, a lot of clients want to know, how long can I get back into activity, into life after surgery? Now, I know you've got both lots of different types of surgeries, but can you give us a general idea of, say, a knee recovery and a shoulder recovery?
Absolutely. So, if you look at shoulder surgery, the majority of the work we do is either rotator cuff surgery or stability surgery or impingement as well. But as a general rule, if we're fixing something, so we're repairing a rotator cuff or fixing a labrum, generally a patient's in a sling for about 6 weeks. They come out to do exercises, they come out for passive range of motion exercises, and all of my operations are protocol driven to ensure that there's quality control. But I say to most patients, you'll hate me for about 6 weeks, you'll get sick of the sling, you won't be able to drive for 6 weeks, it'll be uncomfortable, your physio will push you hard, but you will more than likely get the outcome you need.
Wow.
So at 6 weeks, a sling generally comes off if you're repairing something, and I usually say a return to quite reasonable function anywhere between 3 to 6 months post-surgery. So if you're having a rotator cuff repair, it's a big investment in your time and effort, and more so than, say, a hip replacement, where patients are up and about quite quickly. People are often shocked by how long it takes to recover from ligament reconstruction or muscle or tendon surgery. With respect to the knee, a knee arthroscopy is a very simple thing for people to get through. They're in and out the same day, and I say generally you walk in and walk out the same day. An ACL reconstruction, you have crutches just for balance and for support as you get your gait pattern back. And I usually say getting back to quite normal function at 6 months, but if you're a sports person, you're talking minimum a year before you're back on the field the way that you would expect to be. But that changes obviously depending on patient biology, your access to physiotherapy, what limitations you have on your work, what your expectations are of work and outside of work. So it's very hard to sort of use a cookie cutter approach to it, but that's a general idea of how long it takes.
That's great. So let's just focus on the knee for a minute, because obviously that's one of your specialties.
Yeah.
A lot of people have OA in the knee.
Yes.
And they get a lot of conservative treatment, and it sort of comes to that point where, when should we go and have surgery? When should we continue on getting through with this knee that's really a problem, but it's not necessarily giving as much pain as it should? What was the line would you draw?
Yeah. So generally patients are referred to you with the diagnosis of knee osteoarthritis. So they've had an X-ray or an MRI performed by their GP. And the GP's trialled simple measures, Panadol osteo or anti-inflammatories or activity modification, physiotherapy, things like that. There's a whole gamut of non-operative options that we can utilise to try and delay the progression towards a joint replacement. And a joint replacement is a fantastic, life-changing operation, but it is an operation that carries risks. People have died, people have had their legs amputated, people have had horrible infections, DVTs, PEs. So my general approach is, if you can maintain the patient's own biology, it's better than just chopping it out and replacing it with Nevlon plastic. So anything I can do to delay the progression towards joint replacement, I like to do. In my hands, that involves appropriate oral analgesia. I do occasionally give intra-articular injections of cortisone and hyaluronic acid. The evidence for that is changing at the moment, because we're finding that the risk of infection goes up with people that have had some injections. Modifying their activity and physiotherapy. And ultimately I say to all patients with orthopaedic surgery that orthopaedic surgery is generally a lifestyle decision. It's a question of whether you have appropriate pain relief, appropriate function to be able to do things you want to do day to day, and if you don't, then you have to do something proactive about it, or you've got to accept it for what it is. So in my hands, I can put back on the patient and say, look, I can keep you comfortable, but the question is, can you crawl around on your hands and knees and play with your kids? Can you go and walk around Rome on the cobblestone streets, in retirement and enjoy it without pain? Can you go for a walk along the beach with your dog and your wife? They're lifestyle factors that really ultimately determine whether someone needs an operation or not. It's not a question of your X-ray looks horrible, let's chop it out and put a knee replacement in. It's a question of, does this knee allow that particular patient to do what they need to do? Because the patient's expectations of what they do day to day differ all the time.
Yep, absolutely. So let's go to the shoulder, because that's your other specialty. So what are the factors that you would say determine a really good rotator cuff repair? And what are the basic keys, if you like, to go, these are the things that are going to make a successful operation?
Yep, so very, very simple. A successful rotator cuff repair is dependent on two things. It's dependent on the structural integrity of the repair and the underlying biology of the patient. So you can have a patient who's fit and healthy with a beautifully vascularized acute rotator cuff tear. If they don't get an appropriate structural repair by the surgeon, they're going to have a suboptimal outcome. You can have a surgeon who does a beautiful, structurally appropriate rotator cuff repair, but if the biology of the patient does not allow appropriate healing of the rotator cuff, then the rotator cuff will fail. And finding that balance is a challenge, because you can put a heap of anchors into a rotator cuff repair and tie it all down and strangulate the tendon and then cut off the blood supply of the rotator cuff, and it won't heal. You can slightly attach a rotator cuff back down to a tuberosity with a fit, healthy patient, but if it's not held properly, it won't heal either. And a rotator cuff repair is basically us holding the tendon onto the bone to enable the tendon to grow back into the bone. And if there's failure of the structural integrity of the repair, or failure of the biology of the patient, things like smoking and diabetes will affect that, then the outcome is going to be suboptimal.
Wow. And so, just finally, shoulder replacement versus rotator cuff.
Yep.
That's also, how do you decipher which way you would go?
Yeah, so at the end of the day, it comes back again to that whole issue of what are the patient's expectations and what they want to do. if you think you can appropriately get a good, stable, biological healing of a rotator cuff, then absolutely go for it. If you can't, and the cuff is irreparable, and we see that quite often in our elderly population with chronic rotator cuff tears, the question is, can the patient function with that torn rotator cuff for longer, or do we have to consider a shoulder replacement? And generally, the shoulder replacement is considered when the pain and decreased function affects the quality of life enough for a patient to be willing for me to chop their shoulder joint out and bring in one in.
Wow.
And the shoulder replacements we do for rotator cuff tears are actually something different to what you'd expect. It's called a reverse shoulder replacement. So rather than having a ball and a socket, we flip it around so the socket becomes a ball and the ball becomes a socket. And it changes the biomechanics of the way the shoulder moves such that you don't need a rotator cuff anymore, and you use the deltoid muscle to control the shoulder movement. And you see them more and more these days, and the outcomes are fantastic. And a number of reverse shoulder replacements that are occurring in the community are actually skyrocketing.
Wow.
because of this technology we have.
Wow. Well, there you have it. I think you'll find that has been some amazing information for you to digest and take in. So thank you, Dr. Kumar.
Absolute
It's been
pleasure.
an absolute pleasure to have you along.
Been great having you.
If you want to find out more about Jai, he's got his new offices just in the junction, and his phone number, I'll just get it right, is 4047-2347, or you can jump on his website, www.drjaikumar.com.au. And I'm sure Jai will be more than happy to answer your questions. If you have any questions that you'd like to ask Jai, if you want to jump on and make a comment, we can probably send them through, and he'll probably get an answer back to us to be able to help you decipher some of those questions that you may have that weren't answered in the interview today. Look, thank you for joining us, Jai.
Absolute pleasure.
Good on you.
Right.
We'll see you next week. We've got an amazing thing happening for you next week. Dr. Kumar has actually allowed us to have an opportunity to go through this actual theatre that we're sitting in, and he's going to show us some implements that he uses, show us all the different things that he uses to actually do the operation, so you don't want to miss it. It's going to be fantastic. Same time, same place, 12:30, Wednesday. Have a fantastic week. Remember, healing is a gift, health a responsibility. See you next week.